Well, as you've probably seen from my website, and whenever I've spoken about healthcare reform, I've always supported the president's objectives and the need for healthcare reform. But I've always also said, the devil's in the details, of what you do and most importantly, how you do it. There are too many uninsured Americans, roughly 36 million Americans, and the numbers I'm showing are roughly 37,000 within the 8th district that don't have access to affordable coverage option, particularly because they often don't have an employer-based option available to them. And so for those folks, there will be the creation of a national exchange so that they can become part of that national pool, which will provide those options. Sure, that's a good question. So let me first back up. So you said, what are the things that you're doing for it? Well, I think firstly, the reasons for it are to expand affordable coverage and choice options to those who don't have employer-based plans, while also moving forward on important insurance reforms that will prohibit the pre-existing condition exclusions, the lifetime benefit caps, and the cancellation of coverage when people need it most. I mean, those are some common elements that whenever you talk about reform are necessary and that people have been very frustrated with. So those are the things that I've been most looking for in terms of support, and also obviously making sure that you preserve the doctor-patient relationship and there's no, government or insurance bureaucracy making decisions about care. But the concerns I've had have been on cost containment, and I still don't think the House bill goes far enough, even though it is a deficit-neutral bill, for us to be able to support these reforms in a fiscally sustainable way. I'll be looking for improvements in the longer-term cost containment measures in the final bill before I would support it. And final bill obviously means, this is our House consolidated bill that we'll be voting on probably tonight or early in the morning. The Senate, it's probably going to take several weeks for them to act on their combination bill because they have two different versions that they're going to need to combine. Once they do that, assuming it garners enough support for passage, then the two bills will go into conference for a final bill. I'll be looking for the preservation of those things that I talked about that are strong in this bill that I think are likely to be there and do exist in the other versions. So I don't think that, unless something were to change, those will remain. But I'd like to see some improvement in the long-term cost containment. As you've heard the President talk about the cost curve and bringing down the rapidly increasing cost curve. There's a number of changes that the Senate Finance Bill includes that I think will be up for consideration, but there's multiple approaches. So I'm just going to look at the outcome at the end of the day when they combine it. There's not one specific thing that I would point to. But the IMAC would be one example, which is that independent commission that looks at Medicare spending, and they'll be allowed to implement changes that create efficiencies over time. That would be one very good example. It was never a litmus test for me. I think I've always said that, and the issue has been just to make sure that there's affordable options by driving competition, particularly in markets where there really hasn't been. And for many folks who've expressed support for a public option, it has been because they have experienced rescission, right, where they've been dropped, or pre-existing condition exclusions, or some other health care, some sort of denial of coverage, like we're not going to cover that treatment even though your doctor is prescribing it. Those are the types of things that sometimes I've heard from many that they're concerned that the profit motive in the private sector sometimes conflicts with the care that they might receive. And so they would prefer a not-for-profit option, which could include a government option. For those who have been expressing opposition to a public option, oftentimes they're misinformed in that they think it means government-run care, or like we're somehow going to, there would be doctors hired by the government. that would not be the case. It's really government-administered care, but in so doing, it eliminates that profit motive that some people have been concerned about. But for those people who don't want even government-administered care, they should have private sector options. So the exchange, a lot of people are confused between the exchange and the public option. The exchange, the national exchange that's being created, is where those who don't currently have access to employer-based options can go, whether they're individuals that are currently in an individual market that's not providing affordable options, or whether they're small businesses of a certain size. They can then go to that exchange, which will include both, private and a public option. One of the things I was looking for is, you may have heard the more recent debate on public option was whether it would be a robust public option. I never quite understood why they used that term, but what it really meant was whether it would link those insurance providers who would choose to be part of the exchange and make their offerings available to this new market of people, is whether or not their reimbursement rates would be linked to a Medicare plus 5 level. And there were those who supported that. I thought that could potentially undermine employer-based plans, because it could make costs lower by being tied to reimbursement rates in such a way that it could pull people out. Well, the CBO score, and remember, deficit neutral means is it within the budget that's been allocated, and it is. And so I can send you a little bit of information on sort of the CBO scoring that shows that. But as far as, is this something that's going to be new entitlement, that's the other thing that I think there was confusions about relative to the public option. It didn't mean that it was going to be entirely paid for. Those individuals who go into the exchange, whether they go private sector or public option, still have to pay premiums, just as those of us who are in employer-based coverage. So it will be it will be paid for by premiums. However, because there are mandates, because to be able to make it affordable for everyone, we need to bring healthy young folks into the pool of insured and spread the cost and risk over everyone, so everyone brings down those rates. And because those who don't have an employer-based plan don't have an employer subsidy to assist with a portion of their premium, as those of us who do, there is affordability credits to help those who will need help to be able to make sure that it is affordable to them. Another thing that I think as we move to conference, the Senate versions, both of them are funded differently than the House version, and I think that's an unlikely provision to remain in the bill, and I would like to see that change. Well, again, I don't know what's going to come to know, but there's a number of different options, but I'll be able to tell you when we get to that point. Well, I think like everything we do, you have to, take your time and determine what's most important, deliberate about it, read it, validate whether what you think is most important is included and the things you think that would be problematic aren't. And then on balance, you come to your decision, and that's how I've approached this as I've approached every other piece of legislation. And there's usually folks on both sides of most things that we look at. It's going to actually improve care for seniors. It improves the Medicare Part D drug coverage by allowing negotiation for even lower prices. That's a good thing. It eliminates the donut hole, which is going to help. I think I'll get you a number, but I think I saw a number. It's like a 50% reduction in what people who've been paying, who've been caught in the donut hole. And I'm guessing it's roughly like 6,500 people in our district are directly affected by that from the research that I saw. Oh, no, here it is. 6,800 are affected by the donut hole. So it actually improves care for 78,000 beneficiaries in our district and the donut hole for 6,800 in the 8th district. And there's a lot of fear because there's a lot of misinformation back from when the first bill came out and the death panel ridiculousness, which was obviously never real, to all kinds of, now they're scaring veterans about this is going to take away their TRICARE, which is also ridiculous, and nowhere in a bill. So, I think as we move forward and we get the final bill, and part of the reason that that there's confusion is you don't want to go educate everybody and here's exactly what's in the bill because it's not the final product yet. But once that happens, in the same way, if you remember with the prescription drug benefit, there was so much confusion initially, and now people are more comfortable with what's covered and how it works and what their choices are, and that took some time. The same thing will be true here, but remember, this was AARP endorsed, and AARP is not in the business of endorsing something that's not good for their membership in the senior community. One other thing I do want to mention, too, is it eliminates copays for prevention and wellness visits, which is also going to be big for seniors who are just trying to stay ahead of the curve, checking in with the doctor, making sure they're healthy. That's going to help.